So our next speaker is Tanu Garg. Dr. Garg is an attending physician in the neurology department at Houston Methodist Hospital. She received her medical degree from UTMB in Galveston, then completed her neurology residency at Baylor College of Medicine, followed by a vascular neurology fellowship at Houston Methodist Hospital. She recently became the Associate Program Director of Vascular Neurology Fellowship, and she's highly vested in medical student, resident, and fellow education, as well as all aspects of the clinical treatment of stroke. The title of her presentation is Lifestyle Modification as a Therapeutic Intervention. Dr. Garg?
Thank you, Dr. Kent. And thank you, Jonathan, for that awesome presentation. So today I'll be talking about lifestyle modification as therapeutic intervention for stroke prevention. And so in terms of our objectives today, we're going to talk about things we already know about from the 2014 stroke guidelines in terms of physical activity, diet and nutrition, and sleep, and then things that we have learned since the 2014 primary prevention stroke guidelines in terms of physical activity, diet, cannabinoids, and stress. So things we know, and we're going to go over a couple of points from the 2014 primary prevention stroke guidelines, and I'll focus on questions that my patients have asked me in clinic. So in terms of physical activity is recommended because it has been associated with decreased stroke risk. In fact, in terms of how much physical activity you should be doing, healthy adults should be performing moderate to vigorous intensity aerobic physical activity at least 40 minutes per day. In terms of diet, the recommendations are that you should have reduced intake of sodium, increased intake of potassium, and then the type of diet that's been told us about is a DASH style diet in terms of emphasizing fruits, vegetables, and low-fat dairy products, and also reducing saturated fat intake. As we mentioned before, a diet that's rich in fruits and vegetables is beneficial and has been associated with lower stroke risk. The diet that I do recommend patients in clinic is a Mediterranean diet, and that's been associated also with lower stroke risk, and we will talk about that a bit more at the end of the presentation. The other question that patients always ask me in clinic is about sleep. So there have been many studies that have talked about sleep apnea as being an important contributor to stroke, cerebrovascular risk factors. However, the data behind sleep and stroke risk has been very mixed. The most recent 2019 stroke guidelines also talk about potentially evaluating patients for sleep apnea. However, the recommendation is still class 2B or class 3. It's not class 1 at this point. I do think that in some patients, like management of sleep apnea is very important in stroke prevention and also post-stroke recovery. So in terms of things that we have learned in the last 7 years since the 2014 guidelines. So in 2018, the U.S. Department of Health and Human Services released the second edition of physical activity guidelines for Americans. And what they recommended was that moderate to vigorous physical activity for 150 minutes per week has been associated with lower risk of all-cause mortality. So what I tell my patient in clinic is, 30 minutes per day, 5 days a week is very important for physical activity. In terms of what kind of physical activity is important, aerobic, muscle strengthening, any kind of activity is better than no activity. So in the past, we would say running, jogging, but now strength training, weightlifting, dancing, swimming, all these activities can be really helpful for management of stroke risk reduction. In terms of diet, we do emphasize on the Mediterranean diet, which involves eating vegetables, fruits, whole grains, and healthy fats. We also recommend weekly intake of fish, poultry, beans, and eggs, and also limiting the amount of red meat intake. The data for the Mediterranean diet comes from the trial called the Predimed Trial that was published in NEJM in 2018. And this trial basically looked at 3 groups. There were 2 groups that were on Mediterranean diet. The first group also had extra virgin olive oil, and the second group had nuts. And the third group was control with reduced dietary fat. And as you can see from the numbers, that both the groups in the Mediterranean diet had 30% risk reduction in terms of primary endpoint, which included MI, stroke, and death from cardiovascular causes. And most importantly, if you look at the numbers, that overall improved outcome was actually largely driven by reduction in stroke, with no significant improvement over the control diet for mortality or MI. So this also actually gives more emphasis on Mediterranean diet use in patients who've had stroke or were trying to prevent strokes. This is one topic I have had actually multiple patients ask me in clinic, so I did want to mention that in terms of prevention versus post-stroke recovery is cannabinoids. So there was a study that was done in 2019 that talked about marijuana use and risk of stroke. And it did show that young adults with marijuana use had 1.82 times higher odds of stroke compared with non-users. And in fact, increased frequency of marijuana use actually increased the odds of having increased stroke risk. And also adding cigarette use on top of all of that also increase your odds. So this study does support the fact that cannabinoid use can be associated with increased stroke risk. However, there are papers that have shown that the opposite. So there was a population-based cohort study that was done with 45,000 Swedish men, and about 1,000 of them actually had their first-time strokes, and there was actually no evident association between cannabis use and stroke in young adults. In fact, the study showed that if you actually remove the other modifiers like drinking, alcohol use, and smoking, then actually there's no risk between cannabis use in young adults and stroke. So the question becomes, is there truly an association between cannabis and cannabinoid use and RCVS, intracranial hemorrhages, and ischemic strokes? And the jury is still out there. So before we move on, the one thing I wanted to mention was I found this paper on working long hours and increased risk of stroke incidence. Before I discuss the results of this trial, I do want to say that we want to take it with a grain of salt, because I'm pretty sure we did have an audience that was able to vote at this time. I'm pretty sure a lot of people work more than 55 hours per week. But what this paper showed was that people who did work more than 55 hours per week had a harmfulness for stroke incidence. But as I said, we do have to take the study with a grain of salt. And then last but not the least is stress. So one of the things that I found a bunch of papers on was, in terms of acute and chronic emotional stress and risk of stroke. And there have been studies that have shown that there has been some association between acute and chronic emotional stress. And in terms of mechanisms, the one that was actually mentioned a lot was sympathetic activity, which can actually cause changes in your blood pressure, reactivity, cerebral endothelium changes, coagulation, or heart rhythm changes, all of the things that can cause stroke. And before we move on to our last slide, I did want to go back to the cannabinoid slide and kind of talk about that a bit more. So in terms of that, they were talking about the risks and benefits of cannabinoids, and they did mention that there has been actually studies, especially in animal models, that have shown that cannabinoids are associated with decreased cerebral edema. They've actually decreased the risk of ischemic stroke and also decreased the size of the ischemic stroke, which was something that was new to me. However, there were also studies that showed that cannabinoids have been associated with decreasing your blood pressure, which is very important in acute phase when a patient is coming with an acute ischemic stroke. So there are a couple of things that we wanted to mention before we move on. But in terms of conclusion, I do want to say that the data behind cannabinoids and stroke is a little bit mixed, and we don't have the actual etiology. Is it worth it or not? So when my patients ask me in clinic, is this something that they should be taking for stroke prevention? At this time, I do say no. And in terms of stroke prevention, I do mention that the most important things that you should be doing is physical activity, as much physical activity that they can do, because it's very beneficial, diet, and also stress management. Thank you.
Right, well, thank you very much for that. That was a very interesting presentation. So do you often have patients who ask you about cannabinoids and
It's
stroke
been
prevention?
actually more than I thought, and that's the reason why I actually spent maybe 5 minutes on my presentation on that, is because I've had multiple patients ask me that, and I was amazed at how much data that's out there now in terms of cannabinoids and post-stroke recovery, because in terms of the receptors we have in our body and in our brain. And so that was something I did want to address today.
Okay, great. So in terms of lifestyle modification, are there certain diseases like coronary artery disease or kidney disease in which those modifications seem to have a bigger effect?
So I think in terms of the 2018 guidelines that were mentioned, I think people with hypertension, diabetes, actually have a more benefit when it comes to primary prevention and also lifestyle modifications. So obviously we're also seeing more stroke in the young now. So I do tell everyone, irrespective of their age and comorbidities, that they should be exercising. But yes, in terms of guidelines, hypertension, diabetes, patients with those comorbidities do better with lifestyle modifications.
So how durable are those changes? How long do you have to do them? Do you have to sustain them for a certain period of time or indefinitely?
So I think in terms of like exercising, so people say even if you do 30 minutes of exercise in a day, it is going to do some benefit for you. So no exercise is better than some exercise is better than no exercise. So even if you do 30 minutes, it's going to make you feel happy that day. You might push yourself to go back to work out the next day as well. And so I do recommend anything is better than nothing. However, in terms of long-term benefits, it is very important that you do sustained daily or maybe like 30 minutes per week for 5 days a week exercise. But even a small amount of exercise is better than no exercise.
So I have a particular interest in the metabolic syndrome, or pre-diabetic state, in which inactivity is clearly a risk factor. So there is some pretty good evidence that medications, specifically for anti-diabetic medications used in metabolic syndrome, do reduce stroke risk. So when do you say, the lifestyle modifications, either the patient's not willing to do them or they're not effective enough? Are you using medications for that?
So far I haven't personally used those medications. However, I am giving my patients more like goals. So when they come and see me in the clinic the first time, give them weight loss goals, I give them blood pressure goals, and then I come back and see them back in 3 months. I want to make sure that they're managing those goals. I obviously have some patients who do really well and then some patients who don't, but I feel like the patients who don't, I think might benefit from those medications as well, actually.
All right. So in terms of your overall strategy, do you work with the specialists in the comorbidity diseases? Do you find yourselves communicating with them? So I find sometimes stroke neurologists might be a little bit isolated while all this is going on in the heart clinic or in the diabetes clinic or kidney clinic. How do you find yourself interacting with the other people taking care of these patients?
So I think at Methodist, that's one good thing is we all work together. So I actually do use Jonathan a lot when I have questions about lipids, and he does help me a lot, especially if I want to put someone on bempedoic acid. We do have a close relationship with the cardiologist as well. So if there's a patient that I'm seeing whose blood pressure is not within our normal goal of less than 130/80, we did talk to them to make sure we are doing as much as possible. Ideally, it would be really nice to have like a stroke prevention clinic where we can actually discuss all of these things together. But I think right now, having Jonathan, having a cardiology clinic, talking to PCPs has really helped develop a relationship with the patient where we're actually tackling stroke prevention from multiple different areas.
Okay, that's great.